Good afternoon. Thank you. Bring you to our next installment in our speaker series. Our speaker today is going to address the issue of transportation and health. On the simplest level, it's important to realize that our transportation and land use systems affect our health. There's no such thing as a system or alternative that simply has no effect. It either helps or it hurts. There are transportation systems that encourage activity and healthy lifestyles, or if not encourage, at least make them reasonably practical and safe. And there are systems that make daily physical activity uncomfortable and dangerous. To be clear, a healthy system supports active transportation, namely biking and walking. There are a few reasons why health should be something we think about as we design our transportation system. A few reasons why it's not enough just to go to the doctor or join a gym. One reason is that some groups have fewer options than others. Our children is one group, and our elder citizens are another. We'll be hearing more about the latter group when our speaker from the AARP comes to talk to you in May. Another reason is that the obesity and diabetes problems will not be solved in the clinic, and our speaker today can tell you more about that. There's an increasing emphasis on health and transportation nationwide, not only among MPOs, organizations as diverse as the Centers for Disease Control, individual school districts, the Office of the Surgeon General, the Kansas Department of Health and Environment, and the American Association of Retired Persons are all taking a hard look at health and transportation. It's also very much worth noting that for all the recent attention, I want to draw attention to this, that this is not a new idea, not at all. A healthy transportation system is just as much a traditional idea from our past. It's something we used to have. So I've been showing some pictures around as we've been talking about this in our region. Anybody recognize this place? Mayberry RFD. That's right, a beautiful little charming walkable place. Some more pictures here. Little trivia, anybody know what RFD stands for? Rural free delivery, that's right. Prior to 1919, rural farmers had to go pick up their mail from the post office or a central depot. Here's another little shot of that. Walkable, all modes of transportation, very traditional. Anybody know what state Mayberry is supposed to be in? North Carolina. Okay, you're ahead of me. Our speaker today is Dr. Justin Moore. He's a board-certified endocrinologist who does consulting work where clinical care and public health come together. He was medical director of Via Christi Weight Management for 4 years before concluding that medical weight loss does not work in the long run. His interest in public health began with the observation that the built environment is working against health and creating an uphill battle against obesity and diabetes especially. He frequently advises his patients to walk or bike to work as a practical and effective means of staying healthy. With that, I'd like to welcome Dr. Justin Moore.
Well, thank you, and I really appreciate the invitation to speak. To get started here, as Jason said, I do run a consulting company in addition to my clinical practice, and one of my clients here in town is Health ICT, which is represented in the room today. A few caveats about me as I talk here. I'm not an engineer, I'm not an economist, I'm not a psychologist, but I do live in the suburbs, right there in northwest Wichita. I do treat people with diabetes, and I do spend money, although I drive about an equivalent number of miles as I bike every year because of some of my own health problems. So as we embark on this, it's important to note that the goals of modern medicine are a little different than they used to be. Medical training and medical practice in general were designed around treating tuberculosis, right? You came to the hospital, the doctor's sick, and you hopefully left well. But we don't treat acute infectious diseases all that often anymore. About 80% of our healthcare spending is on chronic diseases. We spend $3.2 trillion per year on healthcare in this country, and obesity and diabetes together make up about a sixth of that. So in addition to decreasing mortality, making people live longer, and making people feel better, our job in medicine has become to do that while spending less money, right? So what I want to do here is just give you a little bit of a tour of some recent, very mainstream medical literature that none of your doctors would be surprised to see. This is all freely available through the National Library of Medicine, and it's just the view out a doctor's window, right? So when it comes to transportation policy, there are really two areas of interest. One is simply car-related injuries, right? We've come to accept car-related injuries as a fact of life, when in fact there are about 2 million car-related injuries per year in this country and about 35,000 deaths. That's equivalent to influenza. The second is the consequences of sedentary modes of transport. Now that there's all this talk of autonomous vehicles and whatnot, there's really a future not that far off where we could literally walk out our front door, be transported to an autonomous vehicle, be taken to the front door of our building, and be transported to our desk, right? And that's in contrast to the 18,000 calories per day that the average farmer burned pre-industrially. So here's our tour, and as we go through these slides, understand how physicians approach the literature. In any study, we want to know who the population is being studied, what the intervention was, what that intervention was compared to, and what outcomes they were looking at. So in the first study, the population are people traveling along 10 bus routes along major urban arterials in Montreal. The intervention was bus travel. Now, they didn't randomize people. They just observed people in buses, right? And compared them to people traveling in cars with an outcome of injury rates for people in the cars or the buses, and people walking along the bus paths, and people cycling along the bus paths. And to make a somewhat complicated study a little simpler, here it is. So here are the outcomes. There you see the routes along the left side of the screen. And along the x-axis of each of these, you see the injury rates. So to get to the bottom line here, if you were in a car, for every mile traveled, you were 3 times as likely to be injured in that car as you were in a bus. If you were walking along that bus path or adjacent to it, you were 22 times as likely per mile traveled to be injured by a car than you were by a bus. And if you were on a bicycle, you were 5 times as likely to be injured by a car than a bus. Again, controlled for numbers of miles traveled. So per passenger, per mile, these are the numbers. So I drive a car. I'm not here to convince anyone not to, but we just have to recognize that there are safer modes of transportation out there, both for pedestrians, both for cyclists, and for people in the vehicles themselves. So how does this translate to other things? I was talking about chronic disease management a couple of minutes ago. There are surprisingly few studies out there that actually directly look at the impact of buses or trains on the health of a community, but we have a good one from fairly recently in Charlotte. So Charlotte installed a light rail in 2007, 2008, so it gave investigators a good opportunity to look prospectively at what happened to the population living within a couple miles of that light rail. So they did a survey in 2008 prior to the introduction of the light rail system, and then did a survey after introduction of the light rail system, looking at the health status and risk factors within the community, specifically outcomes of body mass index, that's how big you are for your height, right? Activity levels, and obesity. What you see on the map, those blue dots are the randomly chosen surveyed households. The red dashed line is the light rail itself. The light blue line is I-77, and the yellow line is the arterial that parallels the light rail system. And here's what they found. So if again, these people were walking about a mile to get to the light rail system, right? So use of the light rail to get to or from work 1 or more times a week was associated with a decrease in body mass index of about 1 point, which isn't huge. You aren't going to see any huge effect sizes in any study that I show you here, but it was highly statistically significant. So if you understand p-values, and many of you probably understand them better than I do, there was about a 98.5% chance of that result being real, right, and reproducible. And then the odds ratio of being obese was about 20% lower. Again, 1 time per week using the light rail. So that's all I have about public transportation, because that's really about all there is recently. The data on this is fairly light, but evolving. When it comes to actually laying out street design and designing where streets go and what buildings go along them, we have a little more robust data stream. So this is a study looking at residents of Toronto back in 2011. And what they did was they compared people living in high density, quote unquote, walkable areas. They defined that as the number of retail destinations, schools, recreation centers within 800 meters. They don't say why they chose 800 meters, but within 800 meters of the center of the population center of a census tract, right? They compared the highest 2 quintiles of those. So they divided all the different neighborhoods in Toronto into fifths. The top 2/5 in terms of walkability and density were compared with the bottom 2/5. They left out the people right in the middle. And they looked at an outcome of who was overweight, who was obese, and who was diabetic. And here's what they found. It's a confusing slide, and I apologize. I'll try to walk you through it. Where you see walking and bicycling trips there, you see that as residential density goes up, there's a sharp increase in the number of walking and bike trips. But if you look at the absolute numbers, they're small, right? So the most walkie-bikey people in the entire study still only did it about every 3rd day, right? So we're not talking about a real sporty population here. These are people that are still walking and biking fairly infrequently. And you see that as the walkability of the neighborhood goes up, that's the blue line, as opposed to the red line, people take more trips. It's no surprise that in those same neighborhoods, public transit use goes up. Again, not huge differences. You roughly double the number of public transit trips, but you're still only traveling by public transit about every other day. And the number of automobile trips goes down from about 1.2 trips per day down to about 0.8 trips per day, right? So not huge effects. But what's interesting about this is that they were able to associate this with fairly positive health outcomes. There wasn't a huge relationship of weight to the density or the walkability of a neighborhood. You could, if you really squint hard for the very, very walkable places, you might be able to see a relationship there. But if you look at the likelihood of diabetes, you start to see something real. So in this country, about 1 out of every 10 people is diabetic. There's about 30 million diabetics in the United States. And that's a little under where they started, right? They started at about 12 per 100 people. But if you go to the most walkable neighborhoods, that number drops down closer to 8 or 9, so close to a 30% reduction. Again, none of this is cause and effect necessarily. This is all observational data, so keep that in mind. But there does seem to be a clear association between walkability of neighborhoods, residential density, and how healthy we are. All right. Second study in regards to this takes the original data set and expands it out to the suburbs of southern Ontario. These are the Canadian cities right next to Detroit, right? And expands it from that 1 year out to about a decade. Looking at high walkability neighborhoods as defined now, not by the number of stores nearby, but by a validated index that goes from 0 to 100, comparing them to low walkability neighborhoods, and looking at the outcomes of overweight, obese, and diabetes. So here's what they found. Again, a kind of a tough slide here, but if you look at the top figure, you see overweight and obesity amongst the study population. And you can see that over the study period, those stayed about the same. And for the first 4 quintiles, those are the non-orange bar there, for the first 4 quintiles, there was really fairly little difference. But once you got to that 5th quintile, the most walkable neighborhoods, you started to see a real difference with the prevalence of overweight and obesity going from the low to mid 50s down to the low 40s. And what's interesting is if you look at the actual walkability score, remember this is a 0 to 100 scale, the most walkable neighborhoods in this still weren't very walkable. They scored an average of 35, but that was still double the average walkability of the next group, right? So this to me lends the thought that there might be some threshold of walkability that we ought to aim for, right? You don't have to go for a perfect Stapleton, Colorado type neighborhood to make this work, right? Even getting yourself to some minimal threshold of walkability may start to make a real difference in metabolic outcomes. And finally, when they looked at rates of diabetes within those same neighborhoods, they found the same thing, right? Really no difference in the low walkability neighborhoods, but once you hit that threshold of maybe 35 or so, you start to see a real association of metabolic outcomes with the walkability of the neighborhood. All right, and just to finish up that study, they found consistent things as related to their previous work, showing that walking and bike trips went up, public transit use went up, and use of cars went down in the neighborhoods that were associated with better metabolic outcomes, which lends some validity to both studies since they got the same results. All right. So enough with Canada, right? How does this apply to American cities? So this study is fun because it takes the same type of research out of big metropolis places like Toronto and into places that are a little more identifiable to most of us in the room. So these investigators from the University of Connecticut looked at these 24 medium-sized California cities, all between 30 and 100,000 people, and looked at high intersection density neighborhoods. That's neighborhoods with a lot of streets crossing, right? A lot of streets connecting, and a lot of streets that were grid-like. So the older parts of town, in other words, right, when we still laid out streets north and south, east and west. They compared those to lower intersection density places with lower connectivity and tree-like street networks. So think the newer parts of town, the cul-de-sacs, right? And compared rates of obesity, diabetes, hypertension, heart disease, and asthma. And they found nothing with asthma. But what they found was that, well, I'll get to that in a second. I forgot I'd put this slide in there just to prove to everyone that engineers can quantify anything, right? So this is the civil engineering sort of approved rubric for looking at streets, where we compare grid-like to tree-like and then linear to tree to grid-like on this X and Y Cartesian plot, right? So what they're ultimately comparing in this study is the grid in the lower right of the screen with the linear tree, the kind of ultimate cul-de-sac neighborhood in the upper left side of the screen, which I like to think of as kind of the neighborhood fingerprint, right? And if you look at my neighborhood, which is probably invisible to the room, I'd say mine most resembles the radial grid there, kind of in the lower middle of the screen. But here's what they found. So when you go look just at intersection density, how many streets crossed within 1 square mile, and you go from 81 intersections per square mile up to 324 intersections per square mile, there's a surprisingly linear drop in the rates of obesity, hypertension, diabetes, and coronary artery disease. And at least for obesity in this study, it was a fairly powerful drop, right? Now understand, people weren't randomized. They controlled for things like sex, age, race, income level, etc. But this is observational regress data, right? But still, if the finding of this study is to be believed, more intersection density, at least up to some point, is associated with better health outcomes. The second thing they did was they looked at the link to node ratio, and I know that there are probably people in this room, Jason among them, that can tell you all about the link to node ratio. All it is a ratio between the number of streets and the number of intersections. So if you look at example A at the bottom of the screen, that link to node ratio is 0.88 because there are 7 streets with 8 nodes, right? However, if you were to connect the streets at the top, the cul-de-sacs at the top and the bottom of that street layout, you would have a higher link to node ratio of 1.13, 9/8. So a perfect grid is 2.5, right? And none of the neighborhoods in this study met 2.5. The highest they got was 2.25. But you can see that as the link to node ratio goes up, more interconnected streets, rates of obesity tend to go down, rates of heart disease tend to go down. Not a huge effect, but remember, this is amplified over hundreds of thousands of people to where the number of people affected ultimately is pretty large. And then the most fun part of this study was when they actually looked at the street layouts themselves. And without belaboring the fact, they found that the best metabolic outcomes were associated with the grid-like street layouts, the lowest rates of obesity, hypertension, and heart disease. Interestingly, the neighborhood, the radial grid pattern, like I think I live in, was about the worst, even worse than the cul-de-sac neighborhood. All right. So that's a quick overview of the literature on this, but it's always risky to depend on individual studies. The best literature in most of medicine comes from systematic reviews. So that's what this is. So this was a systematic review of 30 studies looking at public policy interventions, comparing active and motorized transport, and seeing how they affected the environment or health in the cities in which they were implemented. And I'll cut right to the chase. You can see that most well thought out policy changes to try to influence the rates of active transport have overwhelmingly positive effects. The one outlier in this study, though, I think is worth pointing out. This was in Copenhagen, where they had a public campaign to try to get people to replace half of their trips under 10 kilometers, so whatever that is, 12 miles, and a third of their trips under 15 kilometers with bicycle use. And what they found was that this was when Copenhagen was undergoing its transformation from a car predominant city to now a bicycle predominant city. There are more bikes than cars in daily use on the roads in Copenhagen now. They found that they unsurprisingly had this huge increase in traffic accidents, right? They weren't fatal. They didn't even all result in injuries, but they were there and somebody had to come and attend to it, and that's what they found. And you'll also consistently find that people that choose to use active transportation in studies like this are exposed to more air pollution, right? So that is one of the negatives as cities undergo this transformation. But I suspect what you guys are most interested in is the dollars and cents of this. There's always a humanistic argument to these things on top of a dollars and cents argument. The two cities, ironically, in America that have the best research in terms of active transport are Minneapolis and Portland, which are intuitively horrible places to walk or bike, right? It's cold and snows 5 feet a year in Minneapolis, and it rains 100 days a year in Portland. But in spite of that, they have a lot of data behind their efforts. So in Portland, they have an ongoing budget that projects out a $605 million local investment in pedestrian and bike infrastructure by 2040. And they're far enough in this that they've been able to track some local health outcomes. And what if they extrapolate their current findings into 20-year outcomes by 2040, they project a savings of $594 million. So the investment itself was essentially a wash. They've put about as much money into it as they expect to get out in direct healthcare costs. But interestingly, if you use the insurance actuarial number for what 1 year of human life is worth, which is $50,000, that's based on dialysis, right? It costs about $50,000 for us to dialyze someone for a year once their kidneys fail. So that's what the insurance people use as the value of one human life for a year. The value in life saved is $7 to $12 billion. So $7 billion would equal 14,000 people in Portland living 10 years longer each as a result of this. As a result of these interventions. That's where the number comes from. So the authors of this study, at least, calculated that the benefit to cost ratio in Portland, which is its own ecosystem, is probably about 3 to 1. So conclusions. I think I'm wrapping up actually fairly close to time here. So the transition away from car-based transportation and the city design that goes along with it and toward a little more concentrated, a little more active transport-oriented city is associated with clear improvements in health outcomes and, if you count the value of human life, at least, decreased healthcare expenditures. Understand the effect size tends to be small, and there aren't randomized trials to back this up. All we have at this, well, there are a few, but they're old and I didn't include them. we're relying mostly on observational data. But I think a very reasonable case can be made that as new things are built in the city, as the built environment progresses, there are a couple ways to do it, and there's one way that's associated with better health outcomes, like Jason said, and there are other ways that are associated with worse, and that's the decision that's up to you guys, I guess. So I think that's all I have. There's my email address. There's the address of Health ICT, which is where I work here in town, and you can also find me at outlier if need be. So I'll stop talking. Thank you.